of responsibility. For the purpose of today's webinar, I am also the chair of the Regional GBV Working Group for East and Southern Africa. And this is the third installation of a three-part series that the Regional GBV Working Group for East and Southern Africa has hosted on behalf of our 16 Days of Activism campaign. We do have simultaneous interpretation available. If you would like to listen to the webinar in French, Portuguese, or Arabic, please do note the instructions on your screen to be able to go to one of those language channels. We please ask that you remain muted throughout the webinar. Since we have simultaneous translation, it's really difficult if we have people who are not muted. And we are also kindly asking that you keep your video cameras off because we have people calling in from all over the world with varying internet or bandwidth strength. We want to make sure that they have the best opportunity possible to be able to stay and listen to the presentation today. So please keep your microphones muted and your cameras off throughout the webinar. If you have questions, please do write the questions in the chat, and my colleagues from MSF, Anna and Rahan, will be monitoring the chat throughout so that they can answer your questions in real time. As I mentioned, since we have simultaneous translation, it's a bit more difficult for us to have an open Q&A. So we want to make sure that your questions do get answered. But please note that you may write all questions in the chat. I saw already a question about French. Please do look on your screen to access French, Portuguese, or Arabic interpretation. Next slide, please. As I mentioned, this is part of our 16 Days of Activism campaign. It's a three-part series that's being hosted by MSF Barcelona, and we're focusing on mental health and psychosocial support, particularly because the last day of the campaign, which was on the 10th of December, is Human Rights Day. And we know that healthcare is a human right. And we want to make sure that everybody within the humanitarian community understands that mental health is a part of that human right. And so we're really pleased that we have a really amazing group of panelists today who will be talking about provision of psychosocial support services to survivors of intimate partner violence in Hebron, Palestine. So without further delay, I will turn it over to the Global Mental Health Advisor for MSF Barcelona, Anna, who will introduce her colleagues who are joining us from Palestine, and we're really pleased to have you all on the line and listening today. Over to you, Anna.
Thank you, Jessica. So hello, everyone, since yesterday. Today I have the pleasure to introduce my colleagues from Hebron. Hebron is a MSF project that has been running since, I think, 97 or 98, with a very well-structured MHPSS component since 2000. For a while, actually, in Hebron, we just had mental health care, and we with the situation lately in Palestine in the last years, with the escalation of political violence, we again integrated medical care. Today, the three colleagues that are going to do the presentation are from the MHPSS team. We have Lucia Uskategi, I hope I'm telling her name properly. She's our mental health activity manager, our MHPSS manager for the field. We have Muna Elzouahiri. Muna is our mental health supervisor also in Hebron, and also has been working for us for several years now. And last but not least, Olga Jabri, which is our counselor educator, working with MSF for many, many, many years, has a counselor educator and an excellent provider of SV care. She's our focal point for SV in Hebron. So without more delays, I'll pass the word to my colleagues there, and hope you enjoy because they have a lot of experience on political violence, but lately developing a lot on domestic violence and on interpartner violence. So thank you.
Thank you very much, Anna. We want to start with a short presentation about our project in Hebron, as is the largest city in West Bank in terms of area and population, where the people is living in different kind of conditions, including between areas and refugee camps. As you know, here the community is affected by the occupation and permanent and very frequent attacks from settlers and from army. All these kind of things create a very complex structure, socioeconomical, intra-family services. And for that reason, mainly, we are present here since 1996, covering mental health and also providing primary health care. We have in this moment different kind of services to improve and to alleviate the psychosocial and physical suffering of the population affected by violence and reduce morbidity and mortality among the most vulnerable population in Hebron Governorate, having or not limited access to basic health services. Next, please. Thank you. We want to explain you that we have these services are all part of mental health and the other services to do a comprehensive care. So we have a mental health helpline working from Sunday to Thursday, where the people can call to receive appointments and also to receive immediately PFA according with the situation. At this moment, we are running 15 mobile clinics around Hebron Governorate, including psychologists, counselors, and community mental health workers. 3 of these mobile clinics are only about reproductive health, also including mental health approach. This has been a very good space where we can approach closer to the population suffering for SGBV and for intimate partner aggressions, because it's a little more secure for them as it's only with gynecologists and midwives. Additionally, we have a consultation room in Hebron City where we can provide individual and group sessions. We have also in the project social workers to support the activities in the basic level of the pyramid, trying to guarantee the basic needs. We are doing in this moment weekly group interventions for psychoeducation, awareness, health promotion, and well-being, additionally to all the groups for support that psychologists and counselors can provide. And this year we started to have in the consultation room too, a safe space for women. They come here with their kids. In this moment, we are having the session 4 times in the consultation room and 1 time on the field, providing an environment where the women and children can take care of their own well-being, participating in recreational activities and learning basic skills as drawing, painting, these kind of things that are compensation or to improve the general state of mental health. Well, here you can see the team that is part of this amazing intervention. We have at this moment 4 community mental health workers doing psychoeducation, mental health awareness, answering the helpline, doing occupational trainings, external referrals, advocacy, safe spaces. Later, we have the counselors that they are doing follow-ups and intervention for male patients in mobile clinics, in the communities, and in the consultation room. We have 5 psychologists following the cases moderate, also in the same setup, consultation room, mobile clinics, and in the community. And additionally, due to the high level of severity, we have once per week a local psychiatrist following the cases more severe. Okay, entering a little more in detail for what is the reason we are together today with you, we want to just refresh a little bit the basic definitions that will be better observed in the case that we want to share with you. So domestic violence or intimate partner violence refers to behaviors in an intimate relationship that causes physical, sexual, or psychological harm, including physical aggression, sexual coercion, psychological abuse, and controlling behaviors. When we talk about domestic violence, usually we say that is the partner, husband, or the person who lives, the male person living with them, with the woman who is attacking our beneficiary. But we have a lot of cases in Hebron project where actually the perpetrator for this domestic violence are other women and the family-in-law for these women. Sorry, can you come back to the previous slide? Thank you. Also, the sexual violence often is together with physical violence, but is hidden. The women can be forced to sex when she doesn't want, right? In some countries, as you know, the women are forced to have a relation with their husbands as part of the religion, as part of the culture, and it's not expected that they don't agree to have these relations. It's a real problem that we are seeing very often in our cases, the victimization of a person who is living with the abuser, can be the intimate partner, the romantic couple, the spouse, or the person that they are feeling love. Please, next slide. So, Ola, the floor is yours.
Hello, everyone. It's nice to be with you. And I will start with my cases presentation. So this beneficiary is 35 years, married, and she has 9 children. She's married now for 19 years. She was forced to get married by her father and her brothers, and she had bad treatment by her father in her childhood. She was married at the age 14, like she was enforced to get married early, also like with early marriage. She was referred to mental health services in mobile clinic. She was telling us about her life, and she told us her husband is not working since almost 20 years, and he finished his secondary education, but they have very difficulties in getting income for the family because he's not working. The support they receive only from the family-in-law. This give more control for the family-in-law in her life. She had bad treatment by her father-in-law, and she doesn't have good relation with her like family-in-law. and she doesn't have support from her family as well related to social support. She suffers since the beginning of her marriage. She was exposed to physical violence by her husband. She mentioned for 3 years that she was beaten physically, and then the different kind of violence is starting to showing up in their relation. She shows anxiety, low self-esteem, and thoughts of worthlessness. During the first assessment, she was exposed to, she mentioned, she was reporting that she was exposed, and she's still exposing actually, to domestic violence and intimate partner violence, specifically by her husband. She expressed her feel at the beginning of stigma of community to start reporting and telling us about she has. She came to mobile clinic, as I mentioned, and with the main complaint about general fatigue, pain, and sleeping problems, headache. And after this medical checkups, she was referred to mental health department in mobile clinic. And she actually, as I mentioned, expresses her fear to mention what happened. But in the first assessment, she was clear also about different level of violence she exposed. As I mentioned at the beginning of marriage, physical violence. Now, like ongoing emotional abuse, like neglect, verbal abuse, insults, negative criticism, ongoing negative criticism for everything that she has. Also, like controlling behavior, she was enforced by her husband to engage in sexual activities without her consent, and also with not accepted actions, forcing pregnancy, preventing abortion. And he's controlling also for her, like preventing her to use any kind of contraception, because he decided and he keeps controlling how many children they will have. She should not say no for anything related to this topic, and she should always showing the feeling of belonging to him. He's controlling her. Okay. So with her, when we started the intervention, we started with her as with mental health intervention. She's showing like every week in mobile clinic, but actually sometimes it was very difficult for her to come for our mobile clinic because he decided not to allow her to go out of the house. Even she used the excuse of coming for medical appointment, and then she's coming to to mental health in mobile clinic, but even though he prevented her to come. So with her, we decided at the beginning, we have the safety plan, and together with the crisis intervention, and we discuss with her safe option, like providing her with emergency contact number for shelters and hotlines. But she said, and this time she's not ready to take an action related to this. But even though we try to have safety plan together, created with details for her and for her children as well, because they are exposed to violence by the father, and they witnessed the father like how he's beating and criticize his wife in front of the children with insults. And together we plan with her like in safety plan, including places to go, and in case of emergency, how to leave the house for safe place, what to do. In mental health, when we start to receive her and we start the intervention, we offer her, as I mentioned, the crisis intervention. And in addition to that, we started with her like working on her self-esteem and empowerment, because she came with a complaint like she's showing low self-esteem with this ongoing harassment and abuse by the husband. We focus on rebuilding her self-worth, help her to recognize her strength and resilience, actually focus on her power and ability to heal and make positive changes in her life, like patient-centered approach, and validate and acknowledge her emotions and experiences, like fear, guilt, confusion, and anger. Give her the feeling that she's heard, respected. Also in our session, we use grounding techniques with her, some exercises. And this is like to give her more space to focus and to relax. As well, self-place visualization, these exercises were used to see herself in a safe space, far away from the abuse, and to imagine herself, her strength, freedom, and safety in this visualization. I can say I always keep reminding her about using the physical activities, exercises, positive coping, coping mechanisms, like mainly physical activities like walking, also to increase endorphin. And we also started to do progressive muscle relaxation. And in addition to that, I use psychodrama, like empty chair technique. With so we have two chairs. She's sitting in one chair, and the other chair is like in her imagination. We try to do the scenario. The empty chair is for her husband, to let her express the suppressed feelings that she has, similar to anger, but for sure in a safe way. And before starting doing these activities, I explained clearly these activities and make sure she's ready to participate and in these activities. So in empty chair also we do like role reversal. She's sitting in the other chair. At the beginning, she was in her chair, talking, expressing her feelings toward her husband, and also toward her father, because he enforced her to get married early, and she said she has a lot of anger toward him, and she cannot express that because of the culture and respect. So she was in this chair and telling her feeling, expressing her frustration toward these two persons. And we do the role reversal, like to switch roles. She was sitting on the empty chair now, in the place of abuser. And she was also mentioned one word, I remember, one sentence, sorry. Why you made me feel worthless? Why? I deserve better treatment. You made my life like a hell. So this was a strong, how can I say, conversation. During the session itself, she was stressed. So even in this exercise, I go back to use a grounding technique with her, like to see objects from the room, to smell something, to touch something, like 5 senses grounding technique. This is for mental health intervention, and we still continue doing our activities and intervention together. She was not only referred. Okay, so could you move the slide?
This is just a guide to check all the events that she's suffering. Yes, as Ryan was saying now, Ola is explaining to us all the intervention and techniques that she used in the treatment. It's not reading any slide. We didn't put it in the slide because it's to open the floor to have a more clear conversation about the techniques used.
In addition to that, she was referred to medical care to follow up with if she has injuries, bruises, to assess any psychological like signs of abuse, and also like to monitoring for any ongoing health issues related like malnutrition. And also because in our mobile clinic where I get used to do the intervention with her, we have our gynecologist and CRH intervention. So she was referred for these services to make sure that she doesn't have any sexually transmitted infection, and also like to present contraceptive options, for sure safe ones like implants and IUDs, because if he suppose that he sees the pills or she's telling him about this, it will be like really big disaster for her. And even though we present the possibility to use contraceptive options, but he doesn't approve it at all, but we still showing her and let her feel that she can make a decision. And in the same time, she was referred to social support. She was referred to our social worker to support for children care and financial support and protection. This is mainly with this case.
So we can move to the next slide. So as you can see, for the explanation of the case, intimate partner violence is not only another case of domestic violence. It's something that involves many points of different practice of neglect, abuse, maltreat, this kind of denigrated traits that one human being can receive. We can see this kind of situations in the Hebron project many times, related also with the lack of stability for the families who are suffering due to the context, the environment of violence around everyone, the lack of income, the lack of stability about a job. We can move to the next slide, please. So we are saying that we are in a cycle of violence. Everything starts from outside, but inside, even starting as Ola was explaining for the mother family, because this beneficiary was her own parents who forced her, who started the domestic violence against her, forcing her to do things that she was not prepared or not willing to do. And since that moment, all the cycle is ongoing, and it's very difficult to go out. How many sessions has you already performed with her?
10 sessions.
10 sessions until this moment. We are doing intervention with her every week in the mobile clinic. As Ola was saying, for that I confirm the number, sometimes she can't come to the mobile clinic because her husband don't let her go out from the house, don't let her go even to the doctor. So it's another kind of violence.
And also we have many challenges, like lack of support system in 2 levels, like lack of social support from her family. Well, this is very big issue. And also like limitation for the local shelters and services. So it's really creating more difficulties and challenges because this support system is not very strong. And don't forget that the abuser, the perpetrator, influence and control, because he is her husband, and she doesn't want to leave the house because she should, because she received a lot of pressure to protect this family and the relationship for the sake of children. So also how it will be seen from the community and cultural norms, as you know, and values. In some cultures, is seen as private family matters. So if someone want to help, to support, to advise from even her small circle of friends is not welcome, because this is very private family matters, also related to contraceptions and pregnancy and this sexual relation.
Additionally, if we want to link her with protection services provided by the government, especially, she don't want to receive real protection per se, because the correct of the legal procedure here is that they need to do a conciliation first, explaining to the husband that she's against of this practice, she's not happy receiving physical violence and these kind of things, and they will need to sit together to agree about something. and she's really afraid about that. She don't want to face him in front of more people saying that he is abusive with her. Also because after they sit in this space, they sign a paper. That doesn't mean that someone will receive her like in a protection house, or that the police or government will monitor that actually he is following the agreement. No, she will need to call again. In Palestine is Family Protection Unit. It's a special branch of the police taking care of this kind of cases. But they expect that the same person who put the complaint at the first moment, call them again to say if the things are going well or not. And also many times, the option is that the families agree about some kind of arrangement inside of the community, like inside of clans, to internally these bad behaviors against the well-being. In this case, not only for the women, also for the children. That actually the law give more relevance to the well-being of the children. That will be the best option to put the complaint, to be honest. To say, yes, you can leave your husband or you can have a divorce and come to live with us. They can't take the children with them, and she will be homeless. That will be the scenario that she's so afraid. No?
Yes, and also mainly because she was also growing up in a domestic violence house. So it's very difficult to go back to the same situation now.
Also, for that reason, her mother doesn't have the possibility to support her in any sense because it's a condition normalized. You know, when you get married, you have to expect this can happen to you. And no one speak about sexual violence inside of the marriage because it's not sexual violence.
And in one session, she mentioned that when we're talking about safety plan, what to do, she told me, like with her family, once she mentioned this, they told her divorce is not welcome at all in her community, and it is like causing social stigma for the rest of the family. And also, if she thinks to do this, she will go back to her family without her 9 children. And she told me, imagine I am in the house with him and he's is beating my children. And the bad treatment. So imagine if I'm not there, what else or what worse he could do for them.
So additionally, she is in the role to be the protection for her kids. And she's receiving many times the beatings and the punch that her husband want to reflect to her kids. Well, this is the case. Actually, it was very difficult to track all the comments and questions at the same time that we were explaining, but we are open to hear or to answer your questions, please.
Thank you. Really, I think this is the first time we've actually had such an intimate view of what a treatment plan looks like for a survivor of intimate partner violence. We've had a lot of different questions, and maybe I'll turn over to Anna or Rehan to see if you could put some of those that have come out clearly in the chat.
I think that one of the biggest questions was around the gender, a bit asking if domestic violence and IPV violence also happens for men. And as you were saying in the chat, I think it's clear that men are also targeted, but still in most of the countries in the world, women and girls are more targeted. Which does not mean that we should not take care of men and we should not have services appropriate for men. There was another question that I was just answering now that I think it's very interesting on what kind of care do we have in place for this kind of cases, for GBV cases. And I'll come back a bit to what we spoke yesterday when I presented the pyramid of MHPSS care. So in Hebron, we have a very big health promotion team that works in different topics, including GBV. So there is a continuous work in the community around GBV care on getting awareness. This work is also many times done by our colleagues from the MHPSS team. So they do joint activities, the health promotion and the MHPSS team. And some of the topics, again, are GBV. Then we have more and more groups of people working, men and women, working on GBV topics on the more psychosocial area. The team is implementing some of the psychosocial programs that I spoke yesterday. And finally, we have, well, before that, we have also, as Lucia was saying at the beginning, we are investing a lot now in Hebron on the safe spaces, so having non-clinical spaces that are proximal to the community on a more recreational, pleasure, social care dynamic. And finally, we have the psychological support for cases that need higher support and psychiatric care. I don't know, Lucia or Ola or Muna, if you want to add to what I just said.
No, really, I think you covered all the areas where we are providing the services. And the positive part to have this comprehensive care, and I insist with the role of the SRH clinics, having only for sexual and reproductive health, is to give the option to follow more closely and more private these type of concerns and cases.
And I want to mention in majority of our mobile clinics, we received women and children. But that doesn't mean also if we have referrals to our consultation rooms, not in mobile clinics, to work with men related to this. And I have a dream, one day we could work directly with perpetrators from not necessarily only men, but the perpetrators themselves directly, because like this, the change will start.
That is a great point. By example, now in the safe spaces, we have together women who are suffering domestic violence from their mothers-in-law or from the family-in-law, and they are coming together for the safe space. So we are doing psychoeducational sessions to explain better ways of communication, to explain how to raise resilience without harm the others, know how to change the aggression behaviors for more kind attitudes among ourselves, especially in the context that all the Palestinian people is living right now.
I see that we have Ryan, but before I pass to Ryan, I'm going to complement something that I think it's relevant to say, which is tapping on what Ola was saying. It's one of the issues that I think we have developing more and more is we gave a lot of training in the last years to our teams, medical and mental health, on domestic violence and on sexual violence. And this changed enormously our capacity of identifying survivors of domestic violence and of IPV in particular. And every year nowadays we have SV training in Palestine to make sure that we keep our detection, basically. And I'm going to give the word to Brian, because then I'll come back to the question on helpline.
Yes, hello. Just to say that there was a question in French within the chat. I answered, but it's also related to what, Anna, you have been mentioning, also Ola and Lucia. So the question was about if we have been trying to minimize domestic violence, like IPV, between men and women when they are married? Did we do something at community level? And that mostly are related to cultural barrier. So for that, I put that we have been trying as much as possible to collaborate within community engagement, also with the men and with community leaders, and also key people within the community, like influencers, etc., among other kind of men groups, to tackle the subject. But also let's keep in mind that not to have this idea that the man is the perpetrator, always attacking, etc. It's much more deeply rooted to what is the image given and the pressure given to men, that they have to express themselves in that unhealthy way. So trying as much as possible to work on the stress management, to work as well on expressing ourselves in a healthier way, and hopefully that it will be better. And that's it. Sorry, I didn't see the rest of the questions because I was answering this one. Thank you. If the team wants to add something, yes, of course. Thank you.
I will also complement saying that we have more and more groups of men, psychosocial groups, and I was just visiting Palestine a month ago, and one of the issues that all of us identified has a need is to prioritize men in our intervention, and exactly because we want to decrease the prevalence of having male perpetrators amongst our patients. So what we also realized is that we have to adjust our intervention to have much more has entry door, more recreational activities for men, and then to progress to more complex psychosocial activities, and to progress to more complex psychosocial skills and discussions. So we have to review that. Something also for you to know is in our plan, not for Hebron, but for MSF Spain in general, that next year we want to develop also a PSS group program for perpetrators. So nowadays we have one on general violence, one on GBV, one on IPV, and next year, if everything goes fine, we'll have one on perpetrators and one for families, which we also think it's very much correlated with that. Lucia, Olga, Ola, do you want to say something else on this issue of men, or should I progress to the helpline?
Just to say that in this moment we have 3 groups exclusively for men. During the year we're running already 9 groups exclusively for men. No, it's not the main purpose to talk about domestic violence. It's about violence in general. So we have different topics each week. It's like modules in the intervention to touch the different ways to react and how to deal with the violence that they are experiencing.
Yes, and for me also, I want to add, we focus a lot now for women in safe space and in general in our groups, because this will start the change for the new generations, because they are the mothers. They will be very careful how to deal with the children and how to raise them up related to this topic. So I think we need a lot of interventions for raising awareness and continue in doing that. Thank you.
Absolutely. And keep also in mind that in these groups that we have for men, we also have former prisoners, and in many cases very focused on torture that they experienced on while in detention, and some of them had experiences, obviously not as perpetrators, but as survivors of sexual violence. So our work with men should continue, and in these 2 dimensions, has perpetrators, but also has survivors in many ways. Jessica was asking me why we have the helpline. We have the helpline. We started the helpline during COVID because we didn't have access to the population, and there was a need to create some form of access. And after COVID, we decided to stay because we know that because of the political violence in the environment, sometimes people cannot reach out to us. It's also true that in some cases of domestic violence, it's difficult for people to get out of their houses and to come to us. So the helpline is still a relevant way of connecting with people and having people connecting with us. Sometimes also we have our psychoeducation groups in the community, in which we obviously always speak about how to get to mental health care. But people might not feel comfortable in that place in front of other people to say, I need support. So then they will call us and they will ask for support. So it's really a way of increasing access for different reasons, and also decreasing the gap that stigmatization of mental health can have when people try to get to care. I don't know if the team want to complement.
No, really, I think you say everything regarding the helpline. That is mainly now used to do PFA in the moment, and we are receiving a lot of calls from people from Gaza, where if it's true that we have physical services, sometimes it's easier to have the phone call, no? When they can't move to the clinics.
And speaking of the war, there were questions around how this project has, let me see here. It was wondering, how has the ongoing war affected the scope and priorities of the project? It sounds like one of the ways you said that you've had increased individuals calling into the helpline, but are there other ways that have affected the scope and priorities of the project?
Well, the project has been since the beginning based about survivors of violence, from the different types of violence, including domestic violence, sexual violence, and for sure, everything that is consequence of the occupation. So actually, the biggest consequence of the current situation has been the raising of numbers. Some difficulties to reach some areas because of the lack of possibilities to move among the areas in West Bank and also in other areas. And the other point has been that, well, the domestic violence rise also as consequence of the critical situation, because in this moment, the majority of the men are without incoming. So you can imagine if that happened also with COVID. You remember when the people were locked in without working, the levels of domestic violence raised. So in this moment, we are having the same. The people has been without a job, without a school, without university, and without the possibility to move out. So you are locked inside of a house, very small, with a person who is your aggressor. So the point is that the cases are more severe and more often. For that reason, we expand the mobile clinics. Before of this situation, we had 4 mobile clinics. Since December, we have 15 to be closer to the community, because it was very complicated for them to access to the other places. Now it's closer, and we can provide the support in the moment when they are leaving the situation.
And speaking of mobile
Can
clinics,
I
go ahead,
compliment just a bit, because I think it's important to say that even if the project was always very focused on violence, for many years, we were basically working as a general mental health and psychosocial care project. In the last years, with the increase of violence, the project has been more and more focused, and the team has been having more and more training on specific types of violence. And we have been also focusing a lot more on supervision and training for severe cases. The other issue, again, is the inclusion of the safe spaces, and something that the project like 2 or 3 years ago didn't have, and we have been developing, is it was very focused on specialized care because there was a gap in the community. But then we realized that the widespread phenomenon of psychosocial suffering in the community was so big that we had to increase our psychosocial care. And we had to do more group activities, and we had to do more counseling in the community. So it went through the mobile clinics, as Lucia was saying, but also through a huge increase on the group activities that we have been having in the last years to be able to cover the huge impact. We did surveillance. We have now regular surveillance also on mental health in Hebron, and the first report that we have people with mild to severe symptoms. 83% of the population that we sampled had some form of mild to severe symptoms. So this is not possible to address just on specialized care and just on individual consultations. So this is also something that the project is trying to shift and to respond to the community. Thank you.
Anna, I want to add something also related to our medical interventions also. We try to cover with communities, like to do more first aid trainings and mass casualties. We have interventions also in hospitals now to support them, capacity building for locals who are working here. So this is also, it comes the same time with the current situation related to the war and what's going on.
Thank you. I think we have time for 2 more questions before our end, because I could listen to this all day. The first one is around the mobile clinics. We talk a lot about that. Even in East and Southern Africa, we have different variations of mobile clinics, and it sounds like you have a working model that is successful. Can you give us a little bit more information on the construct or how it works? Your mobile clinics, is it a van that goes out with specific staff? Is it attached to a clinic itself? Is it more of an outreach? And then the second and probably last question of the hour is, how are you also dealing with or supporting your own staff who are not only delivering these services in such a super complex environment? So I can't imagine the stress that they are feeling just day to day, just by living in this in Palestine. And then also their full focus is on persons in crisis. So it's kind of a double complexity in terms of the stress that they must be feeling. And so first question is about mobile clinics, and then the second question is about self-care and also how you are monitoring burnout and other types of trauma just within your own staff, providing mental health and psychosocial support. Over to you.
Thank you. I will start with the mobile clinics topic. In general, has been agreements with the Minister of Health from Palestine to reach the most vulnerable communities farther from the centers. Sorry, we have a lot of noise. Farther from the centers, from the health centers, the people who is far from hospitals or big cities. So at the beginning, the mobile clinics were mainly only in Bedouin areas. But as we were saying, since last year, when the conflict raised in this way, the people have more complications to reach the facilities. And additionally, the capacity to pay to doctors, nurses in the Ministry of Health has been a challenge. So for that, we agree with the Minister of Health to use their facilities, the MOH facilities in some other small villages around the city to provide these services is primary health care, including the sexual and reproductive health. And as I was saying, always we have mental health component, psychologist or counselor, community mental health worker, in addition to health promotion, and also someone who monitor the red flags about the humanitarian situation. That is more or less. And the social workers are visiting these mobile clinics in some frequency They have a roster to also receive, and they're receiving their referrals from all the team all the time. So that is the point of the mobile clinics. We are not working right now in the model of a van or a caravan, something like this. We are using more physical facilities to provide better care. But all the time we are working in the improvement of the physical space to have a privacy, confidentiality, and this kind. Sorry, someone said that you are not hearing?
We're hearing you well, actually.
Yeah.
Okay.
Lucy, can you clarify the team? Because I think the team is also very interesting, what we have in the mobile clinics. It's a very comprehensive team.
So, thank you. The team is at least 2 general practitioners, 2 general doctors, 3 nurses, 1 pharma, 1 midwife, 1 gynecologist in rotation by the clinics that are for sexual and reproductive health, 1 psychologist, 1 counselor, 1 community mental health worker, 1 health promoter. I think that's all.
And the crowd controller, which is also important
Yes,
because it's
and we
a lot
have
of people.
community leaders, sorry. We have also community leaders who support us to prepare the agenda and to help us with the people who is coming to the mobile clinic. In average, we receive in the mobile clinics 100 patients every time that we have the session there. And we are doing, the majority of the mobile clinics are weekly. In some location where the number of population is low, or where is another organization providing a complementary service, we are going every other week.
Thank you,
Hello?
Lucia. Yep, I can hear you well. And well received on your model in terms of the mobile clinics, because I think it's an interesting one that we can all learn from as well. And the last question about staff self-care, and I
But
don't know if that's
just to add that this is not a model, an MSF model. So it's something that we adjust according to the place. In
from
many
health,
places,
right? The Ministry of Health.
in other places, in other countries, we would have sometimes a tent, or sometimes we would have a community center, or some. So it depends a lot. What we try has always is to have a very comprehensive team. Many times it's difficult, for example, to have a gynecologist, as you can imagine. But more or less, we try to have medical staff, medical doctors, nurses, health promoters, community mental health workers, counselors, and/or psychologists.
And Anna, maybe since I have you on, maybe you can start being the global advisor. How are we supporting staff, national staff work, and even international, I shouldn't even discriminate here, who are working on the front lines, providing these services, but also living in the environment in which this stress is being created? Over to you.
So first of all, I think it's important to say that in MSF, for example, I provide support and strategic technical support to the field teams that interact with patients. Our support to patients is completely separated from this support because we understand that it would put, ethically speaking, it would not make sense to mix the support of the teams with the support that we provide to communities. So our health staff unit has a specific area on psychosocial care for our staff. We have been developing a lot in the last years, but I don't think it's still enough. We have usually, we try to identify in each country a consultant to provide psychosocial support to our staff. And there's always also psychosocial support in remote. Every office has a phone number that anyone can call to this to the people in the helpline at whatever time. The problem with the helpline is that not always we will have available people speaking the different languages of the staff that we have. So that's why it's important to have someone at country level that can speak the language of local stuff. It's not always easy to find someone that can provide that stuff. It's many times extremely difficult because many times we are also in areas very remote, and the quality stuff that we can find are in the capitals or capitals of provinces. So it's complicated. What we try to do in these cases is to have kind of like a remote care as well, and to have the consultant visiting the teams once per month, more or less, to do individual and group sessions. Again, it's not perfect and it's not working very well everywhere. In Palestine in specific, we also have our health insurance also covers, and for many of the international staff, and in other places, the health insurance also covers several number of consultations. So individually, the person can also tap on the health insurance and get psychosocial support. There are places that have been extremely difficult, and we had to hire international staff to go to the field to provide psychosocial support. It's difficult because it's also difficult to have a continuum of care in this situation. For example, we had in Gaza and now we don't have anyone, and it has been extremely difficult just to have remote support for the staff there. So ongoing, we are very aware of the need, but very far from being perfect, Jessica.
Great. Thank you, Anna. And thank you to all of our presenters today. As I mentioned, the last day of the 16 Days of Activism was Human Rights Day. And I think it's really pertinent that we presented from Palestine today, where we know how so many human rights violations are going on and the impact that's having on women, men, boys, and girls on a whole, right? And we can relate it to GBV, but just massively and more comprehensively. So I really want to thank our colleagues from Palestine for joining us today. I know it was probably very difficult, the circumstances in terms of Wi-Fi and other things. And I just want you to know we really appreciate your work. And we're happy, or not happy, but just really so much gratitude for what you're doing in such difficult circumstances. And thank you to Anna and Rand for joining us again and being so active in the chat and answering all these questions. As I mentioned, I think this is one of our most practical webinar series where we really got into actually what it looks like to provide these types of services in such a complex emergency environment. So thank you so much to everyone. This is the last event for our 16 Days of Activism campaign here at the Regional GBV Working Group for East and Southern Africa. We will be still disseminating some of our videos, which we're highlighting adolescent human rights defenders from throughout the region. So please do continue to promote and share those videos widely, because we really want them to go viral for the right reasons. These are amazing individuals who are doing really awesome activities and interventions on behalf of their peers, and we couldn't be prouder to promote them here in East and Southern Africa. So again, thank you to the MSF Spain team for joining us for the past 3 days, and thanks to all of our participants who have been online with us from Tuesday, Wednesday, and Thursday. We appreciate you and the work that you're doing every day in the field. And I hope you will join us in the future for all of our upcoming events. As we mentioned, we do have learning events throughout the month, each month. So please do join us for those. And then also you can access this webinar series and all of our previous learning events on our YouTube channel. So please do look on our YouTube channel. If you go on to YouTube, and search GBV AOR, you'll come to our YouTube channel and you'll be able to access this webinar in addition to all of our previous ones. So thank you again, everyone. My name is Jessica Gorham, and I'm the chair of the Regional GBV Working Group for East and Southern Africa. And we were so pleased to have all of you online with us. And for those in Kenya, thank you for joining us on this national holiday. We do appreciate it. Thanks, everyone. Thanks, Anna. And to the team for MSF Spain. You are so appreciated, and the work that you are doing is so needed. Thank you all, and I hope to see you online again soon. Bye, everyone.
Thank you. Bye.
Bye.